Thank you so much. Thank you. Okay, so as we all know, as Ms. Binti Basir has also told us, that FNSD, or in other words, functional neurological symptom disorder, was previously known as conversion disorder. We will talk more about the symptoms of the disorder, and obviously we'll move to the treatment as well. But first, we will look at a little bit of the history of the disorder. Next slide, please. History. Yes, that is it. So, when we come to the history of any kind of a mental disorder, it starts back, way back in ancient times. And when we talk about ancient times, we talk about Greek philosophers, and then we talk about Egyptian philosophers. So, back then in Greek, there was a physician known as Hippocrates. So, Hippocrates, first, when looked at the disorder, he kind of explained it as uterus wandering around in the body, and he coined the term hysteria. So after afterwards, there came the era of Middle Ages. In Middle Ages, as we all know, it was the era of witchcraft. It was the era of black magic. It was the era when everybody used to link any mysterious happening to witchcraft. So in the Middle Ages, what happened was that this disorder was linked to demon possession, demonic possessions, and then it was linked to witchcraft. After Middle Ages, we came the 19th century. So in 19th century, there was a Jean Martin Charcot. So Martin Charcot was a French neurologist, and he was studying hysteria. Back then it was known as hysteria. So he was studying hysteria in his hospital in Paris, and there he talked about it as hereditary degeneration. So when the news circled around, it came to Freud, and a lot of you, if you are with the background of psychology, you must know about Sigmund Freud. So when the news came, or when the topic reached Mr. Freud, who was already working on the patients in his domain, he researched on the disorder, and he, as famously as he do, he actually joined the term hysteria with psychological conflicts. That was his favorite part of the game, right? So Freud always talked about psychological conflicts, how every disorder was linked back to the childhood traumas and unresolved conflicts in the mind, right, in the subconscious or unconscious mind. So after Freud, in the early 20th century, the dilemma kept on going. So in the early 20th century, it was believed that Freud's research, or the Freud's psychoanalytical explanation for the disorder, was the correct explanation. But then came world wars, and when World War came, it brought with it a lot of soldiers with different mental disorders, and obviously a lot of soldiers showed the symptoms of this particular disorder. So when they showed the symptoms of this particular disorder, uh, they were termed as shock, shell shock, right? So the terminology for the disorder back in the world wars was either shell shock, or it was termed as neurosis, and it was again joined with the war, so it was called as war neurosis, when they saw it in the male soldiers that came back from world war. Later came our DSM, our good old DSM. When the DSM came, it categorized the disorder as conversion disorder. So it explained the disorder as conversion of psychological distress into physiological symptoms. And in the early 21st century, the neurology was at its peak. So everything was be the neurologists were trying to explain every disorder under their domain. So what they said that was that the disorder FNSD, now termed as FNSD, is actually because of structural abnormalities. So that was the explanation that neurological advances gave to the disorder. And then the terminology changed. I would like to add here as well is that the term conversion disorder was actually changed to FNSD in 2013. But in Pakistan, it's been a recent trend that now we are recognizing, or we are actually applying the term FNSD. Up until a few days ago, or you can say up until a few weeks ago, everybody was still calling conversion disorder, and everybody still knew only conversion disorder. So the terminology changed, and current understanding of the disorder is that it is actually a neurological plus physiological plus psychological disorder, and it has its roots in all these factors. Moving on to the next slide, please. Right. So, first of all, we know the history or the background of a disorder, and as psychologists, then tend towards the symptomology of the disorder, so that in later years, when we are dealing with the clients, we can understand from the way that they tell us about their symptoms, we can understand at which category and in which disorder category the symptom is going to fall. So now we will talk about the symptoms, the causes, and risk factors for FNSD. Next slide, please. Right. So when you look at FNSD from DSM criteria, so it states that it can be one or it can be more than one symptoms that have a physiological effect, that when you look at it, it's more of a physiological disorder. It depends on the movements and your senses. There can be, so when in application, when I am dealing with the clients, I have dealt with many FNSD clients, and in my experience, I have seen people with all kinds of symptomologies. Some people say that they lost their eyesight. Some people would say that they cannot walk anymore. Some people will say that some people will have seizures, and some people will have movement disorders. So all these physiological symptoms, but they don't have any medical condition or medical explanation for it. So if a person is claiming that they cannot see anymore, and yet if all the medical tests are being done, it actually comes out that nothing is wrong with their eyes, particularly, but there is something wrong with the psychologically. So one most important thing, if you all have read DSM, so the most important criteria in every disorder is that whatever the disorder is, it has to linger with your daily life, right? So there has to be an impeccable distress in your daily life. It can be in your personal life, it can be in your occupational life, it can be in your educational life, but it has to impact, significantly impact your any part of your life. So these were the criteria, or these are the symptoms. So this is the textbook explanation of the symptoms, but when you are in practice, you see diversity of symptoms. But the main thing that lies behind that diversity is always the same, that there are physiological manifestations with no psychology, with no medical explanations, but there are psychological explanations. Next slide. So specifiers, when you look at any disorder, there are there are details to it, right? So specifier means what is the type of, exactly what type of seizures are coming in FNSD, whether it's weakness, as I said earlier. People can say that they cannot move anymore, and yet they don't have any medical reason for that. So we have to specify which type of the symptoms they are presenting with. So when we make our reports and when we report the case further, we have to know. So all these specifiers that you see on the screen right now are actually have their own codes. So when you report them, you report with the codes, and you look at all these specifiers, and then you look at the client, and then you understand at which category the client is lying. Say for example, if they have a weakness and paralysis, you specify with that FNSD with weakness and paralysis. So if that is not the case, if they have tremors or if they have gait disorder, so you specify FNSD with abnormal movement, and then in bracket you actually specify what kind of abnormal movement were they manifesting. So with swelling symptoms, as I said earlier, the symptomology is very diverse in this disorder. It is a very unique, and it is still in research. In people are still researching on this disorder, and this disorder manifests in many ways. And you cannot wonder what I have seen in my experience with this disorder. So we specify with that. Obviously there's acute episode that has less than 6 months. If the episodes have been coming to the client's life for the less than 6 months, then you specify for that. That would be called acute. And if it has been occurring for more than 6 months, or if 6 months have passed the day they came to you, you specify that it's persistent. So with persistent FNSD, it's a bit more difficult. When a short time span has passed, it becomes easier to treat the client than the persistent one. Next slide, please. Thank you so much. So we come to the causes and risk and prognostic factors. Through research, we have found out that the reasons for FNSD to occur can be within any of these ranges that you see on the screen, from genetic to environmental, or it can be either of these factors or any one of these factors, right? So genetic and psychological, physiological factors might include something like that. They have been dealing with some other physiological disorder. They have been dealing with something similar to this disorder, and now that disorder has surpassed or has been cured, but the symptoms persist. So, for example, a person who has an history of epilepsy still gets seizures. However, there are no certain evidences of epilepsy anymore. So they will still have seizures, and then we will look at the history. Then we look at how the difference has come, and then we look at all the assessments, and then we finalize that now it has surpassed the or the category of the physiological or genetic disorder. It has entered the category of psychological disorder. Then there are temperamental factors. When we talk about temperament, we talk about a pre-morbid temperament. So as psychologists, when we look at temperament, we compare how the client was before the occurrence of the symptoms of the disorder, before that, and now how the client is after the disorder. So if whether we would look at whether the client was always edgy, a person is always on the edge, and whether the person was very calm in nature. Very, very, very rare thing to happen that a person with very calm nature and person who is very composed gets onto this disorder. But still, we look at the pre-morbid temperament, and we look at how the person was and how the person used to deal with things before the occurrence of the disorder. So we look at the temperamental factors. And then comes the environmental factors. So in Pakistan, I've seen in my practice that the more impactful factors are environmental factors, the most impactful, I would say. So these are the factors that would happen most. And these are the factors such as stressors at home, such as frequent fights at home, such as some traumatic event. For example, something happened to the client in the near past, or is happening, or is still happening to the client. So we look at all these environmental factors. We look at the home environment of the client. We look at the stressors in the life of the client. We look at the family dynamics of the client, and if the client is at school, we look at the educational dynamics of the client, and if the client is of occupational nature, we look at the occupational environment of the client. Next slide, please. So cultural trends. This is very interesting. For the last 10 plus years that I've worked in the field, I have seen all kinds of trends, and mostly cases that come to the OPD are after the acute episode, the acute phase has passed, and now it's in a persistent phase, and they would come to the OPD then. For example, a person would come to with an FNSD after 7 months of FNSD. Sometimes 8 months have passed, and in all these 7 to 8 months, you won't believe this, but even the most literate parents, most educated people, would come and say that we thought that the person was possessed, and they would tell us that. So I would share a case. So I was this of all the cases, this was the most interesting case that came with FNSD. A lot, but yet it was the most interesting case, and they said that we thought that she was possessed. So we took her to a PG, and the PG did something to her, and before she could move, but after going to the PG, she even stopped moving, and that PG made it worse. So, in those cases that have been persistent in culture, in Pakistani cultural perspective, specifically those cases, what happens is that the client becomes so boxed up that it becomes very difficult for the psychologist to build a rapport with that client, because that client has been going through a lot, and the parents have gone through everyone, or the client's relatives have gone to anyone and everyone, yet the psychologist. So they would try everyone, yet the psychologist, and they would come to us the last. And unfortunately, there are so many quacks in the industry, in our industry. There are so many quacks, and people have done just bachelor's, BS in psychology, and they call themselves psychologists. And these people will take these clients to those psychologists, and they will make it even worse. So after circling around, and after getting through with the peers and with these BS psychologists, or someone who has done just a diploma, or just a regular something, some certified course. This is also another thing, that people would do a certified course, and then they would call themselves psychologists. So what happens in all these cases is that the person, if you're an authentic person and you are sitting there, and the client has come to you with an FNSD symptoms, and it has been a persistent FNSD, and they have been through so many things, and now the problem will be here for you to build a rapport and make the client trust you. And not only the client, but the parents or the loved ones that have bought the client, also make them understand that it will take a bit time now. So it's very interesting disorder when it comes to our cultural trends, and it's a very interesting thing that I gave you people an introduction, and I gave you people a history. And when we look at our cultural trends, it seems as that we are stuck in the Middle Ages. uh, let's see. So treatment, when we come to the treatment of this disorder, we keep moving to the next slide, please. Thank you. So when we come to the treatment of this disorder, there are few steps that we have to follow. First of all, as I said, as I already gave you a build up. So in my build up, I already told you. Somebody said that, can we get a little namaz break, please? I don't know. Maybe Binte can tell us about that. Binte, can you answer that question? Are you there?
Yes, yes. Sorry, but the time limitation is there. We have only 1 hour, so we have to complete the session and question answer session as well in this hour.
Okay. So I guess if you don't want to miss out your namaz, then it's completely fine. Take 2 to 3 minutes, and you can go and say your prayers. So, coming back to repo building, so as I said earlier, as I told you in the cultural trends, the basic problem that comes over here will be repo building. So, repo is when you are making your client. I've got a question. I've got a question as well, Miss Pinte. Can people watch this webinar live if they have not registered?
Uh, it will be uploaded on the YouTube channels and other online platforms. You can watch it there.
Okay, okay. Thank you so much. Okay, so this will be recorded and will be placed on the YouTube channel of PsychPAK. Unfortunately, it won't be available on my YouTube channel, but it's okay. Repo building. So repo building is when you have a connection with your client and the client feels understanding, and that the client feels that he can talk to you about anything, he or she can talk to you about anything, and you have created that safe space and safe environment for the client to open up. So, in any case, in any mental disorder case, the most important part of the treatment is rapport building. Specifically, so I would really emphasize on this, specifically in schizophrenia and schizophrenia related disorders, personality disorders, and in OCD, and then in FNSD. So these are the four disorders that every disorder needs rapport building, but these four disorders, if you have a good rapport with your client, there will be such a fast improvement that you would be astonished. And what how can we achieve that? We can achieve that through empathy, through understanding, through not questioning them a lot. Okay, Arbab Ashfaq has asked me to repeat the names of the four disorders. So, schizophrenia and related disorders, Arbab, and then there are OCD. So OCD and trichotillomania, these two form anxiety disorders, and then there is FNSD. All right, personality disorders. So these are the four disorders: personality disorders, OCD and trichotillomania, FNSD, and schizophrenia and related disorders. So repo is very much important in these four because the client is always questioning. They always have doubt in their mind in these specific disorders. Then we take the history, obviously. First you build the repo. Once the repo has been built, then they would tell you the exact incident from where it actually got triggered or it actually started. So as I was telling you about that case of mine, that was a very interesting case, and the parents, it was a young girl, and the parents didn't know a lot about her life, and they thought they knew about the life. So once the repo was built, she told me the exact point or the exact stressor from where the disorder was originating. This is a very short webinar. I cannot go into the details of the treatment and into the details of how we actually do the techniques on the client, but I will get you through the basic surface pointers of the treatment. So differential diagnosis is very important. You have to see if there is any there is any medical condition. You have to see if the seizures or the tremors or the weakness is coming from any medical condition. So medical tests are very important in this particular disorder. It is very important that you collaborate with medical professionals, and you actually prescribe the client to take all the tests before making any kind of judgment for the disorder. So it's very important. Please note that. Uh, Often our young psychologists do not understand the importance of this, and I would again emphasize that you have to talk to them, to go to medical professionals and get all the tests done. There must not be any medical condition, there must not be any epileptic seizures. All right. So After that, eclectic approach is used. What is eclectic approach? So eclectic approach is when you take techniques from all the therapeutic models and you use those techniques from different therapeutic models. So sometimes some psychologists would use, sometimes some psychologists would use only CBT. Okay, cognitive behavior therapy. Some psychologists would use only DBT. Some would use only behavior therapy. So in eclectic approach, what you do is you don't stick to one particular therapeutic model, but you take techniques from different models and you apply on the client. In FNSD specifically, we take techniques from behavior therapy, cognitive behavior therapy, and then exposure therapy sometimes. It depends on the situation. Okay, so that would be an eclectic approach. Then the third step is DTRs. You can see on the screen there is DTR, identifying or identification of underlying factors. That would be you take the records. DTR is a type of technique from CBT. It's like a baseline chart. You ask them to record the instances of the seizures of, or the events occurring in their life. So they have to give a record of what happened and what was going on, what was the trigger, how did it happen, and what was going on in their mind, what was going around them, and so on and so forth. And then through those DTRs, through those baseline charts, we understand the underlying factors of the disorder. Then the fourth part of the treatment is extinction, face saving, differential reinforcement coping treatments. So, what are these? So, what we do is that once we've identified the underlying factors, we apply extinction. Now, it's again based on the severity of the disorder. If this is one of those disorders in which we actually recommend that the client should be hospitalized. Okay, keep this in mind. This is also a very important point. In schizophrenia and in FNSD, if we look at the severity, even in the other mental disorders, if there is a chance of harm, we would go for the hospitalization. But in FNSD, because we have to apply extinction and we have to look at all the factors, for example, if the parents would comply with extinction, there are many cases where parents don't comply with extinction. And so if the client is at home and they are in the safe, the client is in the safe environment of the home, people are loving them, parents are loving them, and you have strictly asked them to apply extinction and they're still not applying extinction, it's no use. It's not going anywhere. It's a very important part of your treatment of FNSD. Trust me, it's the most important part of the treatment of FNSD. So we have to apply extinction. And if there is a lot of severity of the disorder, then we hospitalize them and apply extinction.